TAVI is actually not that new of a procedure. Trials started back more than 8 years ago. There's already current indications for TAVR for patients with aortic stenosis who are inoperable or high risk for aortic valve replacement. So these have already made AHA/ACC guidelines. What we're seeing now is expanded indications for TAVR as the technology improves and as methodologies for these procedures get better. These procedures have gotten a lot more safe, and we're seeing expanded indication to intermediate risk patients. The PARTNER 2 trial was the first one that was reported at ACC this year, which showed non-inferiority of TAVI to surgical AVR in patients who are considered intermediate risk for aortic valve replacement. I think we're going to see continued expanded indication for TAVI in more and more patients with aortic stenosis. TAVI and TAVR are the same. Initially, the acronym TAVI was the first one used, short for transcatheter aortic valve implantation. In fact, in Europe, TAVI is still used. TAVR stands for transcatheter aortic valve replacement. It is a functional replacement. Both acronyms refer to the same procedure. In the United States, the preferred term is TAVR. So initially, with inoperable and high-risk patients, this meant we were able to treat about 4% of patients with aortic stenosis with TAVI. With expanded indication to intermediate risk patients, anticipate to be able to treat as much as 10% to 15% of patients with aortic stenosis. So these are the highest risk patients. Average age of the PARTNER 2 trial is about 81 years old. But these are patients I think benefit the most from a minimally invasive procedure in short recovery time. So it allows the clinician to offer more options for their patients with aortic stenosis. A lot of these patients either have a combination of age, comorbidities, or frailty that make them higher risk for aortic valve replacement. Previously, we were only able to treat the very high-risk patients. Now we're seeing a greater segment of patients that would be a candidate for TAVI, and I think most of us are hoping for expanded commercial indications for TAVI, TAVR in the next several months. TAVI is fairly well spread in the United States. However, there is some signals that centers that offer TAVI in a very high volume center offer the best outcomes to our patients. Although the procedure has gotten very easy in terms of the procedure itself, it does require a multidisciplinary valve team, which includes a cardiologist, cardiac surgeon, anesthesiologist, echocardiographer, and it's really this heart team that optimizes outcomes for our patients, not just intraoperatively, but also preoperatively and postoperatively. The procedures become fairly standardized, and the steps have become a lot easier to perform. I think the biggest iteration of these valves is the very small delivery systems that we're able to use. A lot of our patients, up to 90% of our patients, are able to get TAVI, TAVR through the groin only. We're very excited about the outcomes from the intermediate risk trials. So one has already been presented at the ACC this year. That's a PARTNER 2 trial. We're eagerly awaiting the results of the TAVI trial studying the Medtronic valve. With positive results from the PARTNER 2 and possibly from the TAVI trial, this opens the door to low-risk trials, which Northwestern is currently participating in. We're hoping to enroll the first patient in the next several months. And those are patients who are considered low risk for aortic valve replacement, and those will be randomized to aortic valve replacement versus TAVR. We're very excited to see the results of this trial and commencing this trial in the near future. So when we talk about risk for patients, these are all patients with severe and symptomatic aortic stenosis. So all of these patients do deserve either an aortic valve replacement or a TAVR. When we talk about low, intermediate, high risk, we're talking about risk for surgery. So patients who are high risk for aortic valve replacement, for instance, very old patients with comorbidities or frailty, who we would predict would not do very well with open heart surgery are excellent candidates for TAVR. However, the question is, with better technology and better techniques, is TAVI an acceptable option for patients with even low risk, who can undergo aortic valve replacement with minimal risk? TAVR valves are constructed of a metal as well as leaflets, and the leaflets are taken from animal tissue. All these valves are pre-manufactured, mostly in the United States, some from internationally. And they're constructed much like surgical valves. These valves are immediately available. We don't think of limitation of these TAVR valves like we think of limitations for heart transplants. Those definitely have a finite number, but with TAVR valves, it's all a matter of manufacturing them. Each company has at least 4 sizes of valves, ranging from 19 to 29, and we tailor the procedure and valve size to the particular patient that we're treating. We found that these 4 valve sizes will cover more than 95% of the patients that we see.